So yeah, we've actually been running exactly 3 years ago today, and we started 3 years ago because we recognized that cardiac surgery at our center needed to evolve beyond traditional perioperative pathways. So the situation we were faced with was a large post-COVID pandemic epidemic waiting lists. We had increased patient acuity, we had long hospital stays. We started ERAS really predominantly as a focus on waiting list and length of stay reduction. But actually, our results ran so much deeper than that. Right from the start, we committed to collecting a wide array of outcome measures. And this enabled us to identify that there was a reduction in morbidity across a number of different domains for patients on the ERAS pathways compared to our conventional pathways. And so really what has driven our commitment has been the results we've seen firsthand. So we now see ERAS as proactive prevention of morbidity complications, proactively making the right decisions and interventions at the right time to keep patients on track and prevent morbidity, which is often a byproduct of the care that we give patients. And I think the other thing that's really driven it is that for staff, I think it has helped create a sort of shared multidisciplinary focus around recovery rather than simply treating complications. To achieve accreditation, this is essentially a process. This process is a commitment to both modernise and deliver proactive and timely evidence-based care. So if I start with patients, I think for them, I would like to think that this is a confidence that they are receiving care that is aligned with international best practice and is delivered consistently across the entire pathway. I think one of the biggest challenges we have in healthcare is variation. So accreditation helps us ensure that high quality care is delivered reliably rather than, depending on individual clinicians and decision making. And I think that consistency is incredibly important for patient outcomes. For our staff, I think accreditation is a recognition of the enormous effort that has gone into building this program over the last 3 years. So ERAS succeeds because the whole MDT buys into the ERAS philosophy and they all work together towards those common goals. I also think that if we think like a little bit more broadly, we at Barts would like to think that we can attract the best talents, we can sort of relinquish the best research opportunities and be seen, sort of position ourselves as a leading centre for cardiac enhanced recovery. Well, the short answer to that question is that external data validation and benchmarking are extremely valuable to us. When you say strong clinical results, I think there are a couple of components here. So first of all, our key performance indicators, so our outcome measures, which are sort of essentially how long patients are staying in hospital, our process measures, which is, how long we're leaving indwelling devices in, drains in, for example, and then our balancing measures, which are our morbidity outcomes. All of these have improved steadily over time. So that's one element. But what we don't have data on is how reliably and consistently we are adhering to evidence-based recommendations. We don't collect that data. And so then for us, the audit system allows us to real-time measure compliance with individual ERAS elements, allows us to identify variation, focus our improvement efforts. And this is useful to us because what we're trying to do is drive compliance up. But I also think it gives us something else which is really important, which is what I mentioned about benchmarking. So rather than comparing ourselves with our historical data over time, we are very attracted to the idea of being able to compare ourselves with other international leading centres, because I feel that when we can see other centres are doing things that we are not achieving, this will force us to inwardly reflect on our service and drive improvements. Okay, so in my role over the last 3 years, I've been in the fortunate position to be in contact with several cardiac centres, both within the UK and Europe. I would say, so many of the centres that we have visited are doing ERAS brilliantly, but I would say I've spoken and been in contact with a lot of centres that are adopting elements of ERAS, often very well. But the problem is to do ERAS properly, you really need to understand that it is the entire perioperative pathway. A lot of centres confuse ERAS with, I believe, early extubation and early mobilisation. This is not ERAS. This is what has traditionally been referred to as fast-tracking patients. In converse, ERAS is the entire perioperative pathway. So the ERAS recommendations have the potential to benefit all patients, not just the straightforward patients, which is often where fast-tracking focuses. And in fact, the more complex and the higher the risk the patients are, the more they potentially gain from the ERAS applications. So I would say that if centres wish to push their programmes beyond a simple fast tracking programme, then absolutely a more structured approach is 100% worth it.